The title is Despite Intervention, Fall Injuries in Elderly Didn't Decline. Janice, you want to tell us a little bit about your perspective on falls? I know it's a big deal for you, and I know you're actually doing some falls programs with some of our patients.
Correct. So if I had read the title of this YouTube today, I probably wouldn't have participated because that is a total misnomer of a title. Despite intervention, fall injuries in elderly didn't decline. That's based on one article that did not use an evidence-based fall prevention program. But it was published in the New England Journal of Medicine, which is why Ford selected it. And that was their finding. However, I do want to point out that there is a Cochrane meta-analysis of 44 studies that has a quite different outcome.
So a couple of comments real quick. Now, I knew that you would not like this study. I knew that you were aware of the study. The real reason was to give you a chance. I wanted to get people some understanding about falls. This is not the first video we've done on falls. We did one about 2 years ago. And I don't want to get political, but I'm going to mention a political candidate. You remember a couple of years ago, Hillary Clinton had a big fall and her face got messed up. Falls are a big deal. It doesn't matter what level of performance you're at. It doesn't matter what type of athletic performance you're at. As you and I were discussing earlier, you often get those among athletic instructors.
Correct. Just a little data, 1 out of 4 people over age 65 fall. For those of you who are not at that age yet, you may have already fallen, even if you have a very healthy lifestyle that includes exercise, or you know someone that has fallen. Last week, I knew 4 people that fell. Amongst people that I know that have fallen have been a fitness instructor, a teacher. You don't have to be unfit. Obviously, there are risk factors to falling, but falls happen in people that are still very involved in their own lifestyle routines. And the reason for that is there are extrinsic factors, which are things outside of us. As we age, we have more intrinsic factors, loss of vision, multiple medications. But the extrinsic factors can be the environment, a dip in the sidewalk. It can be dual tasking, which is looking at your cell phone while you're walking. And these are real live examples that I know people that have fallen. Environmental issues, trip hazards. And classroom is a very good place for that, for teachers.
For trip hazards.
Yeah, they have things at a low level if they're working with young children. It's a very experiential environment, and that can cause tripping for the adult. So it's true, as we age, we have more and more risk factors, but even before we hit that 65 years, we are all capable of falling. And the interesting thing about falls is, and I don't remember specifically with Hillary if she had a subdural or not. Something reminds me of that. But a lot of people will have a subdural hematoma in the brain with a fall and not know it. But that actually puts you at more risk for later cognitive decline. Even a car accident can cause that, where your brain gets shaken up a bit.
When you were talking about people, high performers, you left out the marathon runner. Mm-hmm. One of your patients is a marathon runner that had a fall.
Right. So I don't know if you wanted to cover this article, but I will say the research that I've read on evidence-based programs for fall prevention have seen the rate of falling decline by 25%. A program that I am currently piloting has a 40% decrease in falls. This is the evidence based on randomized controlled trials, et cetera. But the single factor that is salient among these studies is that, and I want to bring this up, this is a very strong point, that exercise alone, means strengthening, resistive training, even flexibility, is not enough. The key barrier to falling, the key intervention is balance. And the literature supports that in a fall prevention program, you need 50 hours of balance instruction to have that decrease in fall rate of 25 to 40%.
50 hours of balance instruction. Let's tease that out for a second. But before we do, let's talk about what the dichotomy that we're seeing. You said, you've made it clear you're critical of this New England Journal article. I think one of the key differences here is that, again, you tend to be talking about younger, healthier folks. They looked at an intervention where they basically just had nurses working with more elderly population.
No, the Cochrane review are for people that have already fallen and are in a fall prevention program.
Okay, so let's talk about Cochrane for just a second for reminders for folks. People say, well, the New England Journal is the best there is. Well, not exactly. Cochrane is really the best there is. And
it was based on 44 studies with randomized control fall intervention.
So do you mind if I finish?
Go ahead.
So Cochrane is, for those of you who are not familiar with Cochrane, it's the Cochrane review systems. They're actually associated with Wikipedia at this point. Cochrane review systems where they basically look at the state of the art. They look at all of the studies that are available in a certain scientific area. So for example, people worry about metabolic acidosis with metformin. And in fact, you'll see that on the Mayo Clinic website. The reality is that's not true. You don't have risk there. And there have been not one, but two Cochrane reviews in that space. So the point you're making is similar here. There's a lot of perception that you can't do anything about falls. However, the people that do science reviews for a living, the reviews of the state of the art, the science that's been out there, all the clinical trials, have actually reviewed this, and they've said, yes, you can have an impact. So maybe you needed to have a little bit different components of the literature review in the components of this article. You want to talk about that a little bit?
Yeah.
What you saw with Cochrane?
Yeah, I think I've already stated that they did see, again, these are people at risk for falling that are in fall intervention programs. And I already mentioned it was 44 studies that were randomized control studies that they reviewed, and they saw a drop in the rate of falls of 25%. The single most factor was intervention, was balance.
Balance as opposed to athletics.
Yeah, and I don't want to spend a lot of time on studies. I'd like to get, to some points that people can make a difference in their lives today as well. I will just say briefly, this study was just with nurses. It was via phone, no assessment, just a standard, written protocol that they read to patients. It was not evidence-based. It was not an implementation study. It was an intervention study to see if this intervention worked, and it did not. Whereas the Cochrane review used evidence-based fall prevention programs.
So on a practical basis, what they're saying is, look, one of the easiest ways we can maybe access a whole lot of patients is nurses in your typical primary care doctor's office.
In that article.
And they set up that kind of nurses making telephone calls out of your primary care doctor's office. And it didn't work.
Yeah.
And one of the things you said was 50 hours of balance training.
Correct. That's what again, we keep referring back to Cochrane, but I'd like to hone in on the point that most fall prevention programs include multiple approaches. Like the one that I'm currently doing a pilot with is called the OTAGO, OTAGO. It's evidence-based. I would not implement a program that was not evidence-based. I'm using it along with health coaching, and I'll describe why in a few minutes. But it's a program that you spend the first 2 months meeting with the patient regularly. You evaluate, again, that's a key point. You evaluate using, and I want to bring up this guideline that anyone can access online. The Center for Disease Control, CDC, on their website has something called STEADI, STEADI. It's an acronym. But basically, it has information for patients and information for health practitioners. The program that I'm using uses the STEADI assessment to evaluate patients on a regular basis. First initial, and then I'm evaluating every 2 weeks. But then the exercises are a combination of flexibility, resistive training, and again, number one, balance exercises. It's not a cookie cutter approach. It's individualized for the patient. There are structured exercises, but then through the evaluation, the person's ability and what they can do, and you change components of it to meet their needs. The reason that I like pairing health coaching with it is I've already assessed the motivation and the health vision of the individual. And a key component of the program I'm using, the fall prevention program, is tracking. And in health coaching, we also do a lot of tracking, which is, you can think about Fitbit, all these ways, Apple Watch, that you can track exercise. But I already know someone's propensity to be data-driven. And the person I'm piloting it with, I know, is very good at keeping that data, which on the Otago translates to a daily exercise log. And the exercises are 3 times a week, and then walking 3 days a week on alternate days than the exercise.
So if I want to prevent falls myself, if I want to take this information and implement it, so the only way I can do it is get into a 50-hour training program and keep logs and all that stuff?
I would start on the CDC website. There's a list of risk factors, and that is a screen. I would start with a risk factor screen. And some of those items I've mentioned are polypharmacy, taking more than one med, and there's data on how each added medicine increases the risk for fall. And I don't have that right in front of me. Polypharmacy, vision changes, walking, gait changes. Go ahead.
So if I could interject just a second and go back in terms of my own personal experience as a medical director. I did some work with Medicare Advantage, and they assign risk that they know from paying for healthcare for patients. One of the items that clearly creates a significant cost to Medicare is people taking sleeping pills, because relatively young or older, you take the sleeping pill, you go to bed, you wake up in the middle of the night to go pee, and you fall.
Right. And most people have something they can modify to help with that, and that is lighting.
Yep.
So environment and footwear are other risk factors.
Rug.
Yeah, for falls. So there's a lot on that website that is available to anyone. If you deem that you are in a high risk category, that's when one of these evidence-based fall intervention programs is important. But there's things you can do daily, such as work on your balance so that you don't get to a point where you experience a fall. And how do you do that? What I do with a lot of our patients, I do this as a health coach, is I do have them practice balance, which you can do when you're dressing, standing on one foot to put on pants. When you brush your teeth, same thing, standing on one foot. Static balance is where you're standing and you're not moving. Dynamic balance is when you're moving. So if you're standing on one foot and you reach overhead with your arm, you're challenging your balance even more. So there's ways to adopt balance training in a very functional way. Now, Ford is doing it within his resistive training. I challenged him to start working on his balance while he does all his resistive training, because he wasn't doing any balance exercises. This is more of an extreme example. For most people out there, I would say, find functional ways to work on balance. Sidestepping is another good way. Even if you look at the assessment, as I mentioned on the CDC, you'll see different foot placements that challenge your balance besides standing on one foot. Another one is standing in tandem with one foot in front of the other, heel to toe. And, you could stand at the sink and brush your teeth that way too, in that stance. So he took it more to applying it to get it over while he's doing his resistive exercise, but that's not something I typically.
Well, back in my 40s and 50s, I was playing
advise.
a lot of basketball, and you were with me there when I was getting undressed for my colonoscopy, and you got frustrated with me about doing that balance thing.
Yeah, he was under anesthesia, and he tried to stand on one foot to get dressed, and then he was like the Leaning Tower of Pisa on me. And I said, sit down. I said, sit down. And I pushed him to the bed.
Yeah, you did. You took matters in your own hands.
And the nurse totally agreed with me that he should not be standing on one foot. But you were doing that training at the time.
It was because I was doing that active training that you're describing for basketball reasons. And then I gave it up. I wasn't doing that. I got focused on just resistance training. And high intensity intervals. And you pointed out just a few weeks ago that, look, what are you doing in terms of balance? And so I had some things I went back and started doing again.
Right. But it's good, like, again, to me, the key thing is to do it functionally. It's also to be aware of when you're dual tasking, which is doing more than one thing at the same time. Like I mentioned, I know someone that fell looking at their cell phone, and, you know, the sidewalk's uneven, you're not aware of changes in the surface. When I walk and my phone rings, I don't answer it. And I just had to make that decision because I, too, did not want to fall. Like, I'm eliminating that risk factor, that environmental risk factor for myself. And I walk a lot. I walk 10,000 steps a day. So usually my phone is always ringing a couple times while I'm out. But I've made that decision based on my knowledge, you know, of this person's fall. It's thinking about what you're doing and the environment you're in, and even your own home environment. What can you change? We had a guest shortly after we moved into this house, and they said, unlike your other house, there's no nightlights. And I said, you know, we haven't gotten them up yet. And then I think Ford and I both went on Amazon and separately bought them. And now we have like probably one every 10 feet in this house. And that's a very easy strategy to implement. Another strategy is most people don't use the stair rail until they have to in terms of physical ability. And again, I've had people fall carrying something with both hands and going up the stairs. Again, your balance is, you know, changed with the object you're carrying. But I personally have used a rail ever since I was pregnant. And we had a kind of a circular staircase in that particular house. And you have to come up with a conclusion, I might have to make 2 trips. And I have had patients that have done that and are a lot safer. I do want to add that there's a major risk factor that we're not mentioning, and that is the fear of falling. It's an emotional response. People have it that have fallen already. Absolutely, you can understand why. But there's also people, and I'm one of these, I'm age 63, I know what the outcome can be of a fall. And even though hip fractures are not as frequent as you might imagine with a fall, it is a major setback. It's like 20 to 30% of people with hip fractures don't have a good recovery.
The way a lot of old people die.
So instead of having the fear of falling that can increase your risk, you have to deal with it and make some changes. Like I said, don't multitask, don't use your cell phone, hold the rail. I don't have the fear of falling because I've implemented some personal strategies.
So I'd like to talk with you a minute about the webinar. People don't understand what the webinar is. It's actually a great way to get some access to healthcare that you're just not going to get any other way. You actually get the lab tests yourself at a local lab, a Quest lab near you, for the inflammation panel and the OGTT and the insulin survey. These are things, inflammation and prediabetes, that your doctor just does not know about. And here's the thing. Harvard Health and many others have said, look, sudden death is not always so sudden. The Hollywood picture that it's a bolt out of the blue is not realistic. It's more like real lightning, preceded by clouds, wind, and rain. Stop that metabolic storm before the lightning strikes. And here's where that metabolic storm comes from. It's inflammation, and it has to do usually with prediabetes. So again, we actually get labs, we go over them in the webinar, and then you can start finding out how you can prevent that heart attack others said that you couldn't even predict. We can show you how. Thanks.